Somewhere in this country, right now, someone is standing in front of an open medicine cabinet, staring at a bottle they've taken every night for years. And they have no idea it might be the reason they can't find their car keys anymore. Not because they're getting old, because of what's inside that bottle. I'm Dr. William, and after 15 years in practice, I can tell you the hardest conversation I ever have with a patient isn't about a diagnosis, it's about a prescription. Because the truth nobody wants to say out loud is this. Some of the most common medications sitting in senior medicine cabinets right now are quietly rewiring the brain. And by the time the forgetfulness becomes obvious, real damage may already be done. Here's what makes this different from ordinary aging. Ordinary aging is slow. It's misplacing your glasses once in a while, blanking on a name, and remembering it 20 minutes later. What I'm talking about today is faster, sharper, and far more preventable than most families realize. It doesn't show up as a diagnosis on a chart. It shows up as a loved one who was razor sharp a year ago, suddenly asking the same question 3 times in an hour. And everyone around them just shrugs and says, "Well, they're getting up there." Nobody thinks to check the pill organizer sitting on the kitchen counter. Today I'm walking you through 9 medications that carry real documented risk to memory and cognitive function in older adults. Medications so common, so ordinary, so unremarkable looking that almost nobody questions them. Some are prescription. Some you can buy without ever speaking to a pharmacist. We'll count them down, and by the time we reach number 1, you'll understand something that changes how you think about every bottle in that cabinet. The danger isn't always the drug. Sometimes it's the combination. Before we start, I want you to do something. Drop a comment with your age, or the age of the person you're caring for, and list the medications you're managing right now. I read every single one, and it shapes exactly what I cover in future videos. This isn't just content to me. It's genuinely the reason I started making these videos in the first place. Let's begin with number 9, and don't let its position on the list fool you. Because this medication is sitting in almost every household in America right now, and most people reach for it without a second thought. Number 9 is diphenhydramine, the active ingredient in Benadryl, and in most nighttime and PM-labeled cold and allergy products. It's cheap, it's on the open shelf, and because it doesn't require a prescription, people assume it must be gentle. It isn't. Diphenhydramine belongs to a class of drugs called anticholinergics, which work by blocking a brain chemical called acetylcholine. Acetylcholine is essential for forming new memories and staying mentally alert. As we age, the brain naturally produces less of it, which means an aging brain has far less room to absorb a chemical that blocks it. The structure that takes the hardest hit is the hippocampus, the part of your brain responsible for turning short-term experience into long-term memory. In practice, I've watched patients take a nightly antihistamine for sleep year after year and slowly lose their sharpness without ever connecting it to the pink pill on the nightstand. This isn't a fringe concern. Anticholinergic burden in older adults is one of the most well-documented risk factors geriatric physicians actively screen for, precisely because it's so easy to overlook. The drug feels harmless because it's sold next to gum and mints at the checkout counter. But harmless and unregulated are not the same thing. Here's the contrast that matters. A 30-year-old brain has plenty of acetylcholine to spare. It can absorb the hit from an antihistamine and barely notice. A 75-year-old brain is already running on a smaller reserve, and every dose lands heavier. That's the piece almost nobody explains at the pharmacy counter, because the label doesn't warn you about cumulative effects over years of nightly use. It warns you about drowsiness the next morning. And here's the part that troubles me most as a physician. This isn't a rare interaction buried in fine print. It's one of the most consistently flagged concerns in geriatric prescribing guidelines. The kind of thing pharmacists are trained to watch for and families are never told about. A senior can walk into any drugstore in the country, buy a box of nighttime cold medicine, often open shelf, and walk out with something that carries real cognitive risk when used night after night for years. No conversation, no warning sticker, no pause at the register. That gap between how a drug is sold and what it actually does inside an aging brain is exactly where this entire list lives. So here's what to actually do with this information. Read the label on anything you take to fall asleep and anything marked nighttime, PM, or allergy relief. Because a large number of these products are simply diphenhydramine wearing a different name. If allergies are the issue, newer generation antihistamines like loratadine don't cross into the brain the same way and carry far less cognitive risk for long-term use. And I want to be completely clear about something before we go any further in this list. Never stop a medication on your own. Bring this to your doctor or pharmacist. The goal isn't fear, it's awareness. Because awareness is the only thing that lets you ask the right question at your next appointment, instead of quietly assuming your memory changes are just age catching up with you. That's number 9. And if you thought that one hit close to home, wait until you hear what's coming at number 8. A medication almost every senior with heartburn has been told to take indefinitely, without ever being told what indefinitely might quietly cost them, both physically and mentally, over the years ahead. Number 8 is a medication your stomach thanks you for, and your brain quietly pays for over time. It's the class of drugs called proton pump inhibitors. The big names are omeprazole and esomeprazole, though you probably know them by their shelf names. These drugs shut down acid production in the stomach, and they're handed out constantly for heartburn, reflux, that burning feeling that creeps up after a big meal. People stay on them for years, sometimes decades, because the moment they stop, the symptoms come roaring back with a vengeance. So it feels like the medication is the only thing holding the line. That feeling is exactly what keeps people on it far longer than most were ever meant to be. Here's the part almost nobody hears standing at the pharmacy counter. Your stomach needs acid for more than digestion. It needs that acid to unlock certain nutrients from your food, and one of the most important is vitamin B12, which protects the wiring of your nerves and supports healthy brain function. Turn the acid down far enough, for long enough, and B12 absorption quietly suffers. Magnesium can follow the same pattern. Starve the body of those building blocks over years, and you can end up with fatigue, nerve issues, and cognitive symptoms, brain fog, slower thinking, memory slips, that look remarkably similar to early dementia, when the actual root cause is a nutrient deficiency your medication helped create. This is where the contrast really matters. Nobody hands a patient a proton pump inhibitor and says, "This might be permanent." It's framed as a short-term fix, but reflux medications have quietly become one of the most long-term prescriptions in modern medicine, refilled automatically year after year, with almost nobody reevaluating whether it's still needed or whether a gentler option would work just as well now. So here's the move. If you take a proton pump inhibitor every single day, and especially if you've been on it for years, That's a conversation worth having with your doctor. Many people can taper down onto a gentler class of medication called H2 blockers, which are generally considered less disruptive to long-term nutrient absorption. Others find that dietary changes, smaller meals, cutting back on late-night eating, reducing trigger foods, allow them to step down the dose considerably. The goal isn't zero medication for everyone. The goal is the lowest dose for the shortest time that actually controls the problem, instead of a pill taken forever purely out of habit because nobody ever revisited the plan. That's number 8. Now, let's talk about number 7, which is prescribed for a problem most people would honestly rather not bring up at all, which is exactly why so few people question what they're taking for it. Number 7 is the class of medications used for overactive bladder. Oxybutynin is the name to know. It's given to seniors dealing with a sudden, urgent need to reach a bathroom, the kind of unpredictable urgency that can reshape an entire day around knowing where the nearest restroom is. The relief this medication provides is real, and so is the embarrassment it spares people. I don't want to minimize that, but oxybutynin works by blocking acetylcholine, the same memory chemical we talked about with diphenhydramine back at number 9. And this particular drug crosses into the brain quite easily, landing right where new memories are formed. That combination, a drug people take daily for years without much scrutiny, that also happens to cross deep into brain tissue, is what makes it more concerning than its quiet reputation suggests. Here's what troubles me most about this one specifically. Patients are told a pill will calm the bladder. Almost nobody mentions that the same pill might be dimming the mind at the same time. So, when the forgetfulness starts, missed appointments, losing track of a simple conversation, misplacing things constantly, the fog gets blamed on getting older. Families nod along. Well, that's just aging. It's rarely traced back to the small pill taken every morning for bladder control, because nobody drew that line for them in the first place. If you take oxybutynin and you've noticed your memory slipping lately, take that seriously and bring it up at your next appointment specifically. You don't have to choose between a functioning bladder and a functioning memory. That's a false choice nobody should have to accept. There are newer medications for overactive bladder that work through a completely different pathway, one that doesn't touch the acetylcholine system at all. And for many older adults, they provide similar day-to-day control with meaningfully less risk to cognitive function over the long run. It's worth specifically asking your doctor whether you're a candidate for one of those alternatives, rather than staying on the first medication that was ever prescribed for the issue years ago. Here's the pattern I want you to notice as we move forward, because it's going to repeat itself for the rest of this list. Number 9 and number 7 look nothing alike on paper. One is an allergy pill, the other is a bladder medication. But underneath, they're doing almost the exact same thing to the brain through the exact same chemical pathway. That's the part that should genuinely concern you, because it means the real danger on this list isn't any single drug category. It's how many different, unrelated-looking medications are quietly hitting the same target inside an aging brain from completely different directions, without anyone ever adding up the total. Keep that thought in mind, because it's going to matter enormously by the time we reach number 1. For now, let's move to number 6. And this one might be the most surprising entry on the entire list, because it isn't some obscure pill buried in a drawer. It's one of the single most prescribed medications on the planet, taken by millions of people specifically to protect their heart. and almost nobody thinks to connect it to their brain at all. Number 6 is statins. Medications like simvastatin and atorvastatin are among the most prescribed drugs on Earth, especially after age 60, and they do an important job lowering cholesterol and reducing the risk of heart attacks and strokes. I want to say this clearly before I say anything else. This is not a case against statins. For a huge number of people, they're protecting the heart in ways that genuinely extend life. What follows is simply the half of the story that usually gets left out of that conversation entirely. Cholesterol does far more than affect your heart. Your brain is made up largely of fat, and it relies on cholesterol to build the insulation wrapped around every single nerve fiber. The layer that lets electrical signals travel quickly and cleanly from one part of the brain to another. Lower cholesterol aggressively enough with a strong enough medication, and in some people, the brain can be left short of a raw material it genuinely needs to function at its best. Not everyone experiences this, but some patients describe a very specific and unsettling pattern after starting a statin or increasing the dose. Moments of real mental fog, a familiar name that suddenly won't surface, a route they've driven for 20 years that briefly feels unfamiliar. Here's the contrast worth understanding. Not every statin behaves the same way inside the brain. Some cross easily from the bloodstream into brain tissue. Others are far more selective and tend to stay where they're needed, working on the liver and the bloodstream without penetrating brain tissue nearly as much. That distinction matters enormously, and it's rarely explained when a prescription is first written, because from a purely cardiac standpoint, the drugs can look interchangeable on paper, even though they behave differently once circulating through the body. So, if you've been on a statin for several years now, and you've started noticing fog, forgetfulness, or a kind of mental sluggishness that feels new, that is absolutely a conversation worth having with your doctor, specifically about which statin you're on, whether the dose is higher than it needs to be, and whether a different option within the same drug class might protect your heart just as well with less cognitive interference. This is not a reason to quietly stop a medication that may be actively protecting you from a heart attack or stroke. It's a reason to get more specific with your doctor, instead of assuming the fog is simply unavoidable. That's number 6. Quick pause before we continue, because we're moving into the part of this list where things get more serious. If this is helping you connect some dots, take a second and hit that like button. It genuinely helps this reach more families who need to hear it before a bigger problem develops. And while you're there, tell me in the comments how many prescriptions you're currently managing, either for yourself or for someone you love. I read every comment, and it shapes what I cover next. All right, back to the countdown. Number 5 is the benzodiazepine class of medications, drugs like lorazepam, diazepam, and alprazolam. These are among the most commonly prescribed medications in the country for anxiety and sleep problems, and they work by boosting a calming brain chemical that turns down an overactive nervous system. At first, for a lot of people, they feel like a genuine rescue. The panic eases. The racing thoughts slow down. Sleep, which may have felt impossible, finally comes. That's real relief, and I truly don't want to dismiss how meaningful it genuinely is for someone in genuine distress. But over time, with continued use, the picture tends to shift. What starts as a short-term rescue can quietly become a long-term chemical sedation of the entire nervous system. Learning slows, mental flexibility decreases. Many patients describe a kind of emotional flatness, as though they're moving through the day behind glass, present, but somehow not entirely themselves. Certain versions of these medications stay in the body longer than others, accumulating gradually in fatty tissue, including the brain itself, which means the effect can build slowly and quietly over months rather than announcing itself all at once. Here's the part of this one that troubles me most as a physician, and it's genuinely different from everything else we've covered on this list so far. If a benzodiazepine is stopped suddenly after extended use, the original anxiety or insomnia often comes roaring back, frequently worse than before, sometimes accompanied by agitation that can become genuinely dangerous. That rebound effect makes the medication feel absolutely indispensable at precisely the moment may be doing the most harm, which is exactly why so many people stay on it far longer than anyone originally intended, simply because stopping feels riskier than continuing. So here is the rule, and I want you to hear this clearly. If you've been taking a benzodiazepine for more than a few weeks, do not stop it suddenly on your own, because doing so can genuinely be dangerous. This is one that requires working closely with your doctor to taper gradually, often over weeks or months, never all at once. There are gentler paths forward for anxiety that don't carry the same sedating, cognitive clouding effect. And there are structured, non-medication approaches to insomnia that have shown real success in helping people sleep without the long-term cost to memory and clarity. The goal isn't to villainize a medication that helped someone through a genuinely difficult season. It's to make sure nobody stays on it for a decade simply because nobody ever revisited the original plan. That's number 5. And we're now entering the second half of this list, the half where the medications get more familiar, and in some cases more surprising than anything so far. Number 4 is a single medication prescribed for 3 completely different problems, which is exactly why it became so widespread, and exactly why almost nobody realizes how much weight it's quietly carrying. Number 4 is amitriptyline, an older antidepressant still widely prescribed today for nerve pain, sleep difficulties, and even migraine prevention. That versatility is exactly why it became so widespread. It looks like a medication that can do everything, but beneath the surface, it's one of the more powerful anticholinergic drugs still in common use, meaning it blocks acetylcholine aggressively, the very chemical every single medication on this list has been circling back to. It blocks it so strongly that with long-term use, memory problems stop being a rare side effect and start looking like an expected outcome instead. Here's the contrast that makes this one so easy to miss. It doesn't require a high dose to matter. A small nightly dose taken for years for something as ordinary as nerve pain or sleep can quietly erode cognitive function with no obvious warning sign until real ground has already been lost. Patients notice words disappearing, concentration weakening, and they assume it's simply part of getting older because nobody ever connected the fog to the small pill they've taken every night without a second thought. If you or someone you love takes amitriptyline, that's a conversation worth having soon. There are alternatives for nerve pain, for sleep, and for mood that carry meaningfully less of this particular burden, and your doctor can walk you through which ones make sense for your specific situation. Number 3 is the one I told you to watch for, because it's prescribed to millions of people for something that sounds completely harmless. It's paroxetine, one of the most widely used antidepressants in a family known as SSRIs. On the surface, it looks like a modern, gentle option, far kinder than many older psychiatric medications. But here's the detail rarely discussed. Paroxetine carries meaningful anticholinergic activity, unlike most other medications in its own family. That single trait sets it apart from closely related antidepressants and quietly ties it back into the exact same chemical pathway every other entry on this list has been disrupting. There's a painful irony sitting inside that fact. The medication is prescribed to help stabilize the mind, and for many people, it genuinely does. Yet over years of use, it may be working against the very clarity it was meant to protect. In older adults specifically, paroxetine is generally considered a medication worth reconsidering when other options are available. And it's actually flagged in formal geriatric prescribing guidelines for precisely this reason. If you take it, that's worth raising directly with your doctor. There are other SSRIs that tend to carry less of this specific risk while offering similar relief for mood and anxiety. Number 2 concerns me more deeply than almost anything else on this list, because so many people taking it never knowingly agreed to take an antipsychotic at all. Medications like quetiapine, risperidone, and olanzapine were developed for serious psychiatric conditions such as schizophrenia and bipolar disorder. Today, they're frequently prescribed off-label to older adults simply for sleep problems, restlessness, or agitation, especially in nursing and care settings where a calmer patient is easier to manage through a difficult night shift. Here's the contrast that should genuinely stop you in your tracks. These are powerful medications originally built for severe psychiatric illness, now often used on seniors who are simply confused or having a hard day. They work by suppressing dopamine, a chemical involved not just in mood, but in focus, planning, and memory. Suppress it enough, and the brain becomes slower, less responsive, sometimes flatter and more distant than the person really is underneath. Families describe watching someone they love seem to fade while still physically present in the room. If you or a loved one is on one of these, ask the prescribing physician directly, why was this started, and is it still necessary, or is it primarily being used for convenience? Many behavioral symptoms can improve through routine, reduced overstimulation, and better sleep and lighting without medication at all. And now, number 1. And here's the twist, because it isn't a single medication at all. It's the biggest hidden driver behind nearly every story I've told you today, quietly running underneath all 9 entries on this list.